on the road. So this tonight is going to be a a little bit longer of a chapter than I remember it being. 131 slides. So I will try not to keep you all night, but I'm not going to shortchange you because this is one of the topics that trips most people up on the registry. So if if I say something that doesn't make sense, if I fly by too fast or whatever, let me know, and we will happily go back. Worst case scenario is we break it into 2 nights. We have 3 lectures left, but your boot camp doesn't start until the 11th at the earliest, and then some of you guys in different locations will be even later than that. But we have time. All right, I built those flex days in for a reason, mostly for the hurricanes that were coming, but we can use them for anything. But with that being said, let's get started. Let me get through these. Okay, so tonight we're going over OB, childbirth, that kind of thing. This is no longer the trauma module. That part is complete. You guys have to take your test and have it done by Tuesday, but there will be trauma involved in this. We're starting the special populations module. So we're talking about childbirth in general, both the good, the bad, and the ugly. This module this lecture is going to get messy. I hate to say it, but then childbirth is messy too. So just be aware. I'm gonna talk about how things should go. I'm gonna talk about some things that can go wrong naturally, some things that can go wrong medically, and in regards to trauma. Most deliveries, thankfully, occur in the hospital, especially if a woman is having her first couple of children, and they've got their whole team there, doctors, nurses, or whatever. We don't have to deal with it, but some people tend to have a lot more than just 1 or 2 kids, and usually by like child number 6, they're almost just falling out. They're coming out with the plug. Occasionally, the birth process will move faster than the pregnant woman expects, or she's unable to get to a hospital. Some of y'all that live a long way from a hospital, you're more likely to see these. I've delivered children in gas station parking lots, ambulances, which ambulance is kind of the best place to do it in EMS. I've delivered in homes. I've delivered at the fire department. You never know when somebody shows up and they're like, I'm pregnant. I'm like, all right, cool. How many children have you had prior? And they say 7. I'm like, oh God. All right. So we're going to deliver right here. You must decide whether or not you can deliver at the scene or if you have time to take the patient to the hospital. And we normally will try to get a head start regardless. So even if an ambulance is there, because like I said, as far as out of hospital births go, that's the best place to do it. So we won't wait. Very rarely will you try to do it at the house, because even if you can get just 5 miles down the road, that's 5 miles closer to the hospital. That's roughly 5 minutes faster that the baby's going to go, the mom's going to go without getting that higher level of care that they're going to need. Because even if everything goes right, there's still a big process that the new mom and the baby have to go through at the hospital just to make sure that they're okay. So the less time that is between when they have the baby and when they get to the hospital, the better. It's just, if you do leave and you don't expect to make it to the hospital, be prepared to pull over. So a real quick anatomy review. The female reproductive system includes your ovaries, fallopian tubes, uterus, cervix, vagina, and breasts. The ovaries are 2 glands. There's one on each side of the uterus, and they are in similar function to the male testes, but only in that they produce that particular gender's half of the baby making process. So the testes produce the sperm, ovaries produce the eggs. And as we mentioned before, remember that the ovaries of a woman they're born with all the eggs they're ever going to need. They don't produce as they go. So, and when they go into their cycle, they pass an egg from each ovary alternating. So 1 month will be the left ovary, 1 month will be the right ovary, and it just keeps going back and forth. This is important for those kind of medical conditions where a woman may lose one of her ovaries, say, due to a cyst or something of that sort. They're only able to get pregnant every other month. Keep in mind also the ovaries and the fallopian tubes aren't physically connected. The fallopian tubes have like a flower end on them, and they just kind of rake the ovaries. And essentially they will grab the egg as it comes out of the ovary and put it into the fallopian tube to be carried down the tract. ovulation occurs approximately 2 weeks prior to menstruation. So the best time, if y'all didn't know this, the best time for a woman to get pregnant is within 2 weeks of her period. Once the period starts, that's usually the end of that window. That's where the body has just decided this month isn't the right month for you, and they get rid of the blood. If the fertilized egg implants in the endometrium, then the lining on the, which is the lining of the inside of the uterus, if that happens, then the whole cycle process of menstruation stops. And then the new mom, usually that's your tip to being pregnant, obviously, is I'm late, that kind of thing. If the egg's not fertilized, then it all just passes through. All right, the uterus is a muscular organ that encloses and protects a developing fetus for approximately 9 months in humans. This organ, like I've said a couple of times, the way it sits in the body is it runs up a little bit and then it folds over and goes posteriorly. So it just kind of sits, it lays over some muscle and the other organs of the body and everything in that area. And if you get pregnant as the baby grows, that the uterus kind of comes forward and out, and that's that's how you see like the woman's stomach will start to grow out and everything. All right, the uterus is where the contractions come from during labor. This is to help push the fetus through the birth canal. And the birth canal is made up of the vagina and the lower third of the uterus, which is called the cervix. It's basically just the dividing line. It's a border. So there's your picture, because who doesn't love pictures? All right, so the vagina is the outermost cavity of the female reproductive system, and it forms the lower part of the birth canal. It's only a few inches deep. It was something like anywhere close to 9 inches or something of that sort. The vagina completes the passageway from the uterus to the outside world for the newborn, and the perineum is the area between the vagina and the anus. Sometimes, especially for a new mom or somebody that's particularly small, they may experience some trauma there, especially during childbirth. So if you're delivering in the field, just be aware. If the baby's really big, the mom's really small, that kind of thing, they may have problems with that. So you may have to deal with a lot of extra blood loss. You may have to do some basic first aid to stop the bleed in that sense. In pregnant women, the breast produces milk that's going to be carried through the small ducts in the nipple that allows the newborn to feed. Obviously, that's up to the mom whether or not they want to go through with that, but physiologically, that's what that's there for. The placenta is a disc-shaped structure attached to the uterine wall that provides nourishment to the fetus. The big thing I want you to know about this is where the baby gets their food from. They have their circulatory system through the umbilical cord attaches to this, and so they're going to get all their nutrients, their oxygen, all their waste is going to go out this way. Carbon dioxide, most of their toxins, and many medications that the mom takes may get into the baby's blood supply through this. In a normal pregnancy, the uterus is going to attach to the placenta will attach to the uterine wall somewhere other than the vaginal opening at the cervix. It could be anywhere in there. It just depends on where the egg hits whenever the fertilization happens. However, as we're going to talk about when we start talking about some of the issues tonight, sometimes that connection can happen at the cervix, and then now you've got problems. So just keep in mind, usually like you can see in the picture, it's all connected up and kind of in front of this baby. It doesn't always connect there. It can be anywhere in there. The umbilical cord is a lifeline for the fetus, connecting the woman and the fetus through the placenta. There's one vein and two arteries. All right, so the vein, and these are backwards from what you've been taught previously. In the fetal circulation, the umbilical vein carries the oxygenated blood. The umbilical arteries carry deoxygenated blood. So that's backwards from what you've been taught for your own anatomy. Let me get to the right slide here. All right, here we go. So the fetus develops inside a fluid-filled bag-like sac called the amniotic sac. The sac contains about half to a full liter of amniotic fluid, which helps insulate and protect the floating fetus. So that way you don't have to worry about if the mom gets bumped or, most mild to moderate trauma is not going to hurt the baby because of this protective sac. But um, obviously that's not a foolproof thing. Again, the body is not designed to handle massive hits, right? If it were, we would never get hurt. The amniotic fluid is released in a gush when the sac ruptures. This is the beginning of labor, so if you've ever heard somebody say that the water broke, that's what's coming out. All right, so normal changes in pregnancy. This is how things are hopefully going to go, and you have an easy night. During pregnancy, many normal changes occur in the body that are not all directly related to the reproductive system. There's a lot of hormonal changes. So and I say this all the time. I hate that people have taken the word hormone and like you must be hormonal as an insult because that's medically that's a thing. Even without pregnancy, if you take birth control, it will make you hormonal temporarily while you're adjusting to the birth control. That's just the definition of it. If you're a preteen teenager that's starting to hit puberty, your hormones are going to be out of whack for a while. You change your birth control or you take antibiotics while you're on your birth control. All these things will cause a hormonal shift. So will pregnancy because you're going from a non-pregnant to a pregnant person. Um, and these are some massive changes for a woman. So that's going to make a hormonal shift. In the reproductive system, hormone levels will increase to support the fetal development and prepare the body for childbirth. There's a couple other things that change as well. The amount of blood in a woman's blood supply will go up. So a woman could technically lose more blood before going into shock. However, that puts the baby at risk. As the fetus develops and grows, the uterus also grows, stretching to accommodate a full-term fetus. As the size of the uterus increases, so does the amount of fluid it contains. And the uterus is displaced out of its normally well-protected position within the pelvic area. Remember, like I said, it folds backwards and into you. So as an organ, it's flat under normal conditions. It's flat. It's deep inside. It's not close to your skin. You really aren't going to damage the uterus in trauma very easily when you're not pregnant. But this is something that could get damaged pretty bad, and it's very vascular because this is the blood supply for the baby as well if you ever get pregnant. If a woman is pregnant and her uterus gets damaged, there could be massive hemorrhage that could be internal, things of that sort. So keep that in mind. That's an organ that we don't normally worry about, but if it's a pregnant lady, suddenly that gets put pretty high on the priority list. Rapid uterine growth occurs during the second trimester of pregnancy. As the uterus grows, it pushes up on the diaphragm. This will make it harder for the new mom to breathe. And when as they get closer and closer to the late stage term, all that space that the baby takes up, plus the weight of the child, will start to cause other issues. Like a pregnant woman can't technically lay, or we don't want her to. At least we don't want her to lay on her back. Because the weight of the baby will put pressure on the inferior vena cava, and that's 70% of your body's blood supply not able to get back to the heart because the child's sitting on that vein. So positioning is important. We'll talk about that when we get to that portion. Overall blood volume gradually increases throughout the pregnancy, like I was saying, mostly because the body needs enough to supply the mom's organs as well as the child's. The number of red blood cells will increase to carry more oxygen. The mother's respiratory rate will increase both because the diaphragm is getting constricted, also because it's just that much more oxygen being taken up by the baby and not the mom. So the mom's going to the hypoxic drive, or rather the constantly higher trend of CO2 is going to cause the mom to breathe heavier throughout the pregnancy. It's not to the point of hyperventilation, but it is something that if you're actually tracking vital signs, you'll probably notice that they trend much higher on that range than what a non-pregnant person would. By the end of the pregnancy, the patient's heart rate increases up to 20% to accommodate the increase in blood volume, and cardiac output is significantly increased because remember how that equation works. All right, so hypoxic drive, a little bit out of the chapter here, but for those of you that don't remember, hypoxic drive is what tells us to breathe. It's our backup system. Normally, our drive to breathe is by how much carbon dioxide is in our system. When the CO2 climbs, our body breathes because it's trying to exhale it out. We call that the carbonic drive. The hypoxic drive is more for COPD and emphysema patients, where their CO2 stays so high for so long that they wind up just kind of burning out those sensors. And so the body can't make its breathing decisions based on carbon dioxide anymore. It needs to do it based on low oxygen. So when the body's backup is, all right, can't really tell how much CO2 I got. So let's look at our oxygen. When it gets below a certain point, we'll breathe. If it gets above a certain point, we'll stop breathing. And that's a concern because if we give them 100% oxygen, our patient, we may shut out our patient's drive. They've gone back and forth over the years about whether or not we'll give oxygen to patients with a hypoxic drive, COPD and emphysema patients. Right now, it's don't hold back the oxygen, but you may want to titrate it a little bit and keep them just on that low range of what's acceptable, just so that we don't shut off their drive, and then keep an eye on them, because if they do start to go into respiratory distress, it's probably that we're over oxygenating. That's what all that was. All right, we talked about this part. In the third trimester, there's an increased risk of vomiting and potential aspiration following trauma because of changes that occur in the GI tract. It's not so much physical changes, it's more just physiologic. Plus the baby being there, putting pressure on the small intestines and everything is going to slow the process of eating, or rather of digestion. So an expectant mom may not be hungry as often, or they'll probably be hungrier. They'll feel the urge to eat, but they won't be able to eat as much as they would like because their digestive tract is not going to be able to push food through as fast. They're much more likely to be nausea and vomiting that's involved in that. Changes in GI motility and the displacement of the stomach upward significantly increase the chance that a pregnant trauma patient will vomit and aspirate if you're unable to clear her airway. So if this is a trauma patient, definitely, yeah, that too. Your body needs a lot more water, so you're not going to let so much of it go, and that's going to cause constipation. But if you're dealing with a traumatic patient that's pregnant, her airway, especially late stage pregnancy, her airway is going to be very critical. She's very likely to aspirate stomach contents and stuff. So make sure you have your suction with you. Whereas, like, you may have decided to leave it otherwise. If this is a pregnant patient, make sure you have it with you. Changes in the cardiovascular system and the increased demands of supporting the fetus significantly increase the workload of the heart. Remember, not all women are healthy when they begin pregnancy, and during pregnancy, they may get worse and worse as they go. Cardiac compromise is a life-threatening possibility, and even if they are in shape and healthy, like I said, once you reach that third trimester and the child is getting pretty heavy, you can cause cardiac compromise just by having the woman lay on her back. Positioning can be a life threat, so it's really important that you account for that when you're treating your patients. Weight gain during pregnancy is normal, not just the child's weight, but also the body's going to want to try to keep a little bit more in reserve for itself as well as for the child during the pregnancy. So some weight gain is normal. I don't know it, I just remember this, but there's a scale, like a trending scale that the OBGYNs will use, where they're looking at your weight and they're like, okay, you should be here. And they're looking at this upward curve. And they're like, you should be here, but you're here. It's either too much or too little or whatever. Usually it's too much. But that is normal. It's normal to gain weight during a pregnancy. Increased hormone affects the musculoskeletal system by making the joints looser and less stable. That is in preparation for the actual birth, because it's like I said, if you've ever had kids or ever seen kids be born, it's not pretty. In the third trimester, changes in the body's center of gravity increase the risk of slips and falls. They're very, I'm going to say, front heavy. So a woman's natural way to fix that is to lean back. But when you do that, you put all your weight on your heels, and then you're much more at risk of slipping and falling, especially when you're trying to deal with things like stairs, for example. All right, for some complications, most pregnant women are healthy. Some aren't. Some may be ill when they conceive or become ill during pregnancy. And you also have to consider that some people may be on drugs of some sort that will change things. We do have a lot of freedoms in our lifestyle to be able to do what we want. And some people aren't the most responsible with it, but it is what it is. So you may safely use oxygen to treat any heart or lung disease in a pregnant patient without harm to the fetus. Don't withhold oxygen from anybody. If they need it, give it to them. All right, diabetes. We've already had the chapter on this, but for this, there is a type of diabetes. It's called gestational diabetes, and it's basically just diabetes due to pregnancy. So gestational diabetes can occur during pregnancy in many women who have not had diabetes previously. You could be an otherwise healthy person and develop it here. Um, Usually, once the child is born, this diabetes will go away. This is not type 1, type 2 kind of thing. It's just for the pregnancy. Usually, it's caused because um, hormones are a little bit out of place. So where they were fine before, insulin's a hormone. Um, Sometimes they may need it. A pregnant woman may control her blood glucose with diet or exercise. She may have to take insulin. It just depends what's actually going on. A pregnant woman experiencing hyperglycemia or hypoglycemia should be cared for in the same manner as any other diabetes patient. That's the beauty of this, is that you still treat it all the same. I just want you as EMTs to be aware that this is something that's typical. Well, I don't even say typical. It's not that uncommon for you to see in a pregnancy. So if you're looking at somebody and you're like, I don't understand why you look like you have diabetes, you're a fitness model or something, or whatever. Like, I don't get it. It's probably because she's pregnant. Hypertensive disorders, these are high blood pressure complications, and this is the big thing that most of your OB/GYN doctors are watching out for when you go to your appointments during your pregnancy. Any new moms or anybody that remembers their pregnancy, remember they're always watching your blood pressure, and they're always harping on, oh, you got to keep this blood pressure down and do these things to keep it from getting too high. And it's because if it does get too high, we run into a big risk of eclampsia. Um, so this complication is pretty common. Your blood pressure is going to rise as you go through your pregnancy, but just like your weight, you want to try to keep it from going too high too fast. If you do start to have hypertensive disorders, or if you're not you, but if your patient does, they're going to get into some issues called preeclampsia or pregnancy-induced hypertension. The biggest issue with these is the risk of seizure. So the condition can develop anywhere after the 20th week. It's characterized by the following signs and symptoms. Severe hypertension. So if you take their blood pressure and it's skyrocketing on, 160, 200, something like that. Severe or persistent headache. Visual abnormalities such as seeing spots, blurred vision, or a sensitivity to light. So it's going to kind of mimic a migraine. And then swelling in the hands and feet. Anxiety will be a part of this because it's messing with your ability to breathe properly. Get that, the blood pressure is making your heart work harder. Um, your patients are going to be anxious. But the reason that I pointed that out is a lot of times your patient's not going to know that they have high blood pressure unless a doctor's been after them about it. And even then, they're not going to know that the reason they called you was because they're pre-eclamptic. A lot of times those calls come out as migraines, and you get there and you find out the woman is pretty far into a pregnancy. It's probably not a migraine. It's more likely going to be this. So check her blood pressure, expect it to be high, and she really needs to go to the hospital. If they're close enough to be able to induce safely, they will. It's a much better option for the hospital to go ahead and induce pregnancy early than it is to chance them starting to have seizures, because that's a life threat for the mom and the child if it goes that far. A related condition, which is eclampsia, and this is the progression of preeclampsia, obviously, is characterized by seizures that occur as a result of hypertension. To treat a patient having seizures, lay the patient on her side like you normally would, maintain her airway like you normally would, administer supplemental oxygen like you normally would, and if vomiting occurs, suction the airway, get her to the hospital, call for a paramedic if you need to. There's some things that an ALS unit can do for you that you wouldn't be able to do. But even then, ultimately, it's just copious amounts of diesel get her to the hospital because if they're to this point, like I said, they're probably going to want to induce labor if possible. Transport the patient on their left side. If you do, this will help prevent the ability, or this will prevent the threat of the baby putting too much pressure on the vena cava and causing a drop in preload, which is going to bottom out her vascular system. We don't want that. That's trading one life threat for another one. All right, bleeding. Internal bleeding may be a sign of an ectopic pregnancy. When an embryo develops outside the uterus, it most often is going to be in the fallopian tube. So anywhere after an egg gets fertilized, it can attach. No, it's supposed to attach in the uterus. That doesn't always happen. As you can see from this picture, the egg unfertilized would have started off in the ovary, came out, got picked up by that fingered looking end of the fallopian tube. If sperm managed to make it far enough into the woman that it's gone into the fallopian tube, it can fertilize the egg there, the egg will attach there, and that is not meant to support the growth of a baby like a uterus is. So that's a life threat. And what's going to happen is as it starts to grow there, it's going to start causing some trauma, and then that's going to cause bleeding, which is going to start to come out. So a lot of these calls are going to be, you're going to have calls that are basically extreme abdominal pain. A woman probably doesn't know she's pregnant yet. These happen very early. With some spotting, which is just little bits of blood coming out. It's not like a period where it's a full flow, but a little bit of blood here and there, and extreme pain, usually on one side of the body. If it doesn't make sense of appendicitis, but it kind of sounds like appendicitis, it's probably this. And this is why we say that every woman of childbearing age is pregnant until proven otherwise, because again, they may not know. They may tell you that no, I'm not pregnant, and it's ignorance because they haven't been tested. They don't know. Um, that's just part of it. So if that's what you're going to, um, keep the idea that they may be pregnant in the back of your mind while you're doing your treatment. For the EMT, it doesn't really change much of your treatment. If you guys go on to higher levels of care, it's a lot of your medications that you give, you either have to give a different amount or you may not be able to give it if the woman is pregnant. So it definitely matters in those cases. Um, the chances of an ectopic pregnancy are about 1 in every 300. So that's actually really, really common. That's not 1 in every 300 that you do. That's just 1 in every 300 period. You're very likely to come across this. And a lot of times even we miss it because we're not thinking about it. You get this woman that could be 49 years old. She's 6 months away from menopause, and it happens. And she's thinking she's not pregnant, not because she's not sexually active, but because she's 49 years old. She's just not expecting to get pregnant at that age. A lot of people don't know that antibiotics will render your birth control inert while you're on it. So they may be like, well, I'm on birth control, and they forget that they're taking antibiotics for a UTI or whatever, and that rendered their birth control inert, so they're susceptible to a pregnancy that they didn't think they were able to have. Um, Ectopic pregnancies are the leading cause of maternal death in the first trimester. So again, because like I said, the fallopian tube is very, very small. It's not designed to expand and move with the changing size of a baby. So we want to catch this quick. And a lot of times it's not really so much that you catch it as an EMT, just recognize the fact that these are not people you want to let sign refusals, that kind of thing. If they're showing signs that might lead you to this conclusion, they really need to go to the hospital. If not with you, fine, but they need to be leaving at the same time you do, um, because this is a serious life threat. Hemorrhage from the vagina in general that occurs before labor begins may be very serious, so call for a paramedic. The amount of vasculature that's in that area, if it's an actual injury and they're bleeding, they can bleed out. They can lose so much blood that they can't recover from it, even with the extra blood supply that they have from being pregnant. In the later stages of pregnancy, vaginal hemorrhage may indicate a serious condition involving the placenta. We're going to go into that a little bit more further on. But if the placenta separates in one spot or another, um, it can cause very profuse, life-threatening bleeds, and it may not even hurt. The woman may be bleeding out and just be like, I don't feel anything. I don't know why it's happening. Or it could be very painful, and we'll go into um, actually we'll go into that right now. It's right here on the slide. So in abruptio placenta, this is where the placenta separates prematurely from the wall of the uterus, most commonly caused by high blood pressure or trauma. When this separates, it rips the uterus with it. So it's going to be extremely, extremely painful. A lot of times patients will report severe pain, but vaginal bleeding may not be that heavy. In placenta previa, the placenta develops over and covers the cervix. So this is something that may not get caught until the end of the pregnancy. And what will happen is when the patient goes into labor, and the baby starts trying to push out, that connection is going to split. And because of that, and this is happening so late in the pregnancy, that there could be a ton of blood. But because it was just the placenta that broke and not that they didn't rip off a piece of the cervix, there's really not a lot of pain. That one, your patient may be heavily bleeding but won't really feel any pain. So she'll be, a lot of times there's a lot of confusion that comes with that because they don't know. And the scary part about this is right before birth. All that blood, the new mom is going to freak out big time because is it my baby? Is the first question they ask. And usually you can be like, no, it's more probably your placenta. Um, let's get you to the hospital before this becomes a problem for your baby. Decreasing the patient's anxiety during these situations can impact how she and the fetus may respond during the emergency. Remember, the more freaked out they are, the faster their heart's beating, which means that if they're bleeding, they're going to bleed that much more. So your bedside manner is extremely important. Try to keep them calm. These two pictures, if you look at this one on the left, this is placenta, or I'm sorry, abruptio placenta. It ripped off from the top of the uterine wall, and that's where the hemorrhage is happening up above the baby. There could be some bleeding, especially just kind of coming, as it fills up the sac and comes out. And then the picture on the right, um, this is placenta previa. This is where as you can see, the placenta is attached over the uterine. I'm sorry, over the cervical opening. So when the mom goes into pregnancy and that starts to spread out, it's going to rip the placenta, and then there will be a lot of blood loss coming out of there. And it's because it's right by the vagina, you're going to see most of that blood come out. There won't be a whole lot of it up in there with the baby. So it's going to look a lot more profuse, or let me rephrase it. It's going to be more accurately profuse. You're going to see the majority of the blood. So you're not so worried about internal bleeding like you would be from other things. All right, abortion. Now, this is not the abortion that we argue over in politics. Abortion is a medical term. It just means premature passage of the fetus before the natural birth. And it can be from any reason, miscarriages or abortions. So the abortion may be spontaneous, like a miscarriage, or it could be induced, and that's what people argue over. But all of it is the same. So in the medical field, when we refer to an abortion, we're not talking about somebody going to a clinic unless That's specifically what we're talking about. Abortion by itself um, is just a blanket term. Yeah, no, I hate it too. Especially when it's natural, because it's, nobody wanted that. The mom didn't want it. It happened, and that is a horrifying experience for the parents. It sucks for us, and we're not even really emotionally attached. It just sucks to deal with that. It's like losing a family member, but even I dare say even worse, because it's you're losing your hopes and everything with it. But we do everything we can to stop this from happening. Unfortunately, sometimes it happens before we ever get the call, and there's nothing that we can do about it. But the most serious complications for a patient are going to be bleeding and infection. Bleeding can result from portions of the fetus or placenta being left in the uterus, so an incomplete abortion, or from an injury to the wall of the uterus. And that, just to kind of drive home exactly how much this really does suck for the mom, if they have a spontaneous abortion for any reason, they still have to deliver the baby. They got to go through everything's got to happen just like if it were a regular birth. It's got to come out. So just finding out that it happened is only the beginning of the nightmare, really and truly. Infection can result from such perforation and from the use of non-sterile instruments. A lot of times that is more likely with what's the term I'm looking for, a voluntary abortion. Sometimes though, especially if you have, like midwives, housewives or whatever, you're doing a lot of your stuff in the house, or even in doctor's offices. Sometimes if they cut corners and they use dirty equipment, that could cause the abortion. If the woman is in shock, treat and transport her promptly to the hospital. Never try to pull anything out. Let it happen on its own, and then place a sterile pad over the vagina. Yeah, no, I don't. There's some jobs in the medical field I know. I can tell you right now, I would not be able to function within them, and that's one of them. I'd be locked up for going crazy just from the amount of stress and depression I would deal with from that. Pregnant women have an increased chance of being victims of domestic violence and abuse. Abuse during pregnancy increases the chance of spontaneous abortion. The more they get hit, the more likely they are to spontaneously abort, even if it's not the uh, the stomach area that they're being hit. Any significant trauma or what's the word I'm looking for? Repetitive trauma, where they're constantly in this flux of trying to heal, can cause problems for the baby, because every time they bleed from a bruise or anything else, the body has to release more platelets and go through the clotting cascade, which thickens the blood, and it can cause issues indirectly that would mess up a pregnancy. Yeah, no, L&D is not for me. The woman is at risk of bleeding, infection, and uterine rupture, especially if the trauma is directly related to that area of the body. If this is what you're dealing with, use a calm professional approach, just like what we talked about with sexual assault and any other abuse. Um, you're the first compassionate person that they're going to deal with. The police and other investigators will have compassion, but their job is to catch the bad guy. Your job is to take care of the patient. So, two different approaches. Pay attention to the environment. If you're in a house, sometimes it's a little hard to find out. They're not always going to tell you they're being abused. So, look for signs of it. Your attention to detail will be helpful in your documentation, especially if this winds up being an abortion case, or not abortion. I'm sorry, a abuse case, because it's probably going to go to court, and they're going to want to know what you saw, how you dealt with it. Um, as always, be very thorough in your report and be very objective. Don't put subjective things in there, because that can be turned against you in those situations. But if you're a little concerned about this, talk to your patient in a private area away from the potential abuser if possible. Something I like to do, um, if I think the woman might be pregnant, if I think she might be abused, anything of that sort, if there's any reason why I think she may not want to be loud about what I'm asking her, I take her to the back of the truck where she's by herself, at least away from her parents if it's a teenager. If it looks like it's abuse, I'll get her away from anybody else in the house because it may not be the husband. It's not always husband on wife or anything like that. It could be um, anybody else in the house. Sometimes it's kids. It could be other kids doing it, especially if they're grown. Um, and the a lot of times, unfortunately, the abused, the mother doesn't want to admit it because she doesn't want them to get in trouble. That despite everything that's happening, she doesn't want to see them get hemmed up. So that can be a difficult situation. All right, substance abuse. Some pregnant women are addicted to alcohol or other drugs. The effects of the addiction on the fetus can include prematurity, low birth weight, severe respiratory distress, or death. Um, I've seen people deliver babies that were perfectly fine despite the fact that they smoked weed and drank. I've seen a ton. I mean, not personally, but let me rephrase that part because I don't want to. I don't want to say something inaccurate. But statistics show that there's a lot of birth defects that come from those things at the same time. So it's not a guarantee. But I'll tell you one thing that I have seen. I have seen a baby have to have CPR at birth because the mom had fentanyl in her system and it depressed the baby's respiratory drive to the point where the baby came out in respiratory arrest. So sometimes these are very serious, especially if the mom is still under the influence of whatever it is, because usually the baby will be as well. Fetal alcohol syndrome describes a condition of infants born to women who have abused alcohol. If you're called to handle a delivery of any kind of addicted woman, pay special attention to your own safety. Sometimes they may know they've been doing wrong or know they've been doing something that might get them in trouble. And so they may not want you there. Not to mention, you're trained to kind of look around and figure out, and you're seeing size up what you're dealing with. If they see you doing that, they may think you're trying to find things to get them in trouble with. So that may up your risk. Keep that in mind when you're doing your size up at the beginning. Um, if this is what you think you're walking into, try to be a little subtle about looking around the room. I mean, definitely look around, but don't make it look like you're taking it all in, I guess is the best way to put it. Or at least don't be alone. But if you're dealing with this, follow standard precautions like always. All right, gloves, eye protection if you need it. If you're going to deliver, you're going to be dressed up like you're in a hazmat suit, so wear everything. Clues that you're dealing with an addicted patient may include the presence of drug paraphernalia, empty wine or liquor bottles, statements made by the family. A lot of times, the family is not going to be shy about telling you that she's on drugs or whatever, or the husband's on drugs, and that doesn't matter because he's not the one carrying the baby. But um, depending on when the last time they used was, you may have an immediate need to resuscitate the baby as soon as it's born. If they've done something early in the pregnancy or whatever, but it's been a while, you're not likely to have to do anything yourself at birth. A lot of times, more likely it's just that the baby's going to have some effects from it. But if they're presently messed up on fentanyl, for example, chances are the baby is as well, and the baby's vitals are going to be way below what it needs to be for life sustainment. Some special considerations for trauma in pregnancy. With the trauma, you have two patients to consider. You have the woman and you have the unborn child. Trauma to a pregnant woman may have a direct effect on the condition of the fetus. Again, if they lose a lot of blood, if they got hit directly where the baby's at, all these things can play into it. And there's a lot of ways that trauma can that a woman can be a victim of trauma. Assaults, like we just talked about, motor vehicle crashes, shootings. These can all be issues. Stabbings, whatever, anything that can affect the mom. Pregnant women also have an increased risk of falling compared to non-pregnant women, like we talked about. As they get more into their pregnancy, they shift their balance a little bit. Not only that, but because those hormonal changes are loosening their joints, it's not just their. Hold on. Okay, so to directly answer your question, yes. That being said, if a child comes out needing resuscitative efforts, I don't know anybody in our field that's not completely burned out that wouldn't still try to do resuscitation even if the child wasn't viable. Um, Sometimes it's you're doing it just for the sake of the family. You know you're not going to get the child back, but it's worth it to try so that the family can see that you at least gave it an effort. This is one of those rare situations. This isn't so much the I mean, very good question. Very good question. We're just on the other end of the lifespan from people who would need CPR normally. If it's an elderly person, that elderly person had the opportunity to decide whether or not they wanted CPR done on them or not, for example, like with a DNR. But for unborn children, regardless of your views on certain aspects of things like abortion and stuff, the child didn't get, at that point, the child didn't say, I don't want CPR. And like I said, if a mom is getting ready to deliver, whether she's on drugs or not, she obviously wanted the child or she would have tried to get an abortion previously. So if the child's coming out compromised, yes, it is very much helpful to try anyway, even if you know you can't save it. It's better. It will help you to try because then you can at least come out of that call going, well, I gave it my best effort, as opposed to, well, yep, wasn't viable and just didn't want to try it. That'll mess you up just as much as it does the parents. How many weeks? What? Yeah, anything over 26 is considered viable birth. Um, Even though that's extremely premature. Um, they are definitely going to need. Yeah, that's they if 26 weeks if you're coming out in the hospital. If you're coming out in the back of an ambulance at 26 weeks or in somebody's living room, you're still considered viable, but the odds aren't in your favor. So as you can see, a 14-week difference, that's over 3 months. That's pretty much the entire third trimester. Good question. Yeah, because that will probably come up in these slides. If it doesn't, I'm glad that's there in the chat now. 40 weeks is what full term is, roughly. Um, because some of your registry questions may tell you a woman is in her 38th week, and then versus her 16th week, for example. 24 weeks, I'm assuming birth happened in the hospital, though. Okay. Yeah, because the IC, or I'm sorry, the NICU is very quick to scoop the baby up and start taking care of it. Um, a lot of times, just even well, if you're giving birth in the house, it's probably because you're not exactly 5 minutes from a hospital. So, like for example, a lot of y'all in this class that are down around South Mississippi, until Poplarville opened up its ER, um, the closest place was either Picayune or Hattiesburg, which is a 30 to 45-minute drive. If you delivered in Poplarville, it was that long before the baby got or the NICU got their hands on the baby or L&D or whoever. Question totally off on test last night and it's driving me crazy. All right, hold that question, Donna, and ask me at the end of the class. We had a 25-week-old and it just didn't look like it could sustain. So yeah, well, you're cutting it close. Like I said, that 24, 26 week range, viable doesn't necessarily mean they're out of the woods. There's still a high chance they may not, but it's within the realm of possibility that they can make it. So that's hopefully you're in the hospital if that's the case. Oh yeah. Well, I'd work it if it was formed enough to take compressions, even if it wasn't 24 weeks. Just like I said, it's it's not just you, or I'm sorry, it's not just the baby. It's going to be the parents who are freaking out because their world's crashing down, and even you yourself are not gonna. If you're in that situation, you're not gonna want to just let it go. Nobody's gonna want to just let it go. It doesn't. If you do, you're probably in the wrong field. So anyway, let me get off my soapbox with that one. When a pregnant woman is involved in a motor vehicle crash or something like that, severe hemorrhage may result from injuries to the pregnant uterus. Trauma is one of the leading causes of abruptio, I cannot say that word, placenta. And remember, that is where the placenta rips off of the uterine wall. It usually is trauma that causes that. You should suspect abruptio placenta with any kind of MOI that involves a blunt trauma. So if they get hit, if it's like an abuse case, or if they're in a car accident, or they fell, um, because they're susceptible to falls. If a woman falls down the stairs, she's high risk for this, because any one of those steps that she landed on could have caused it. Common symptoms include vaginal bleeding with severe pain. Again, if there's pain involved, that's your abruptio placenta. So you've got damage and trauma to the actual uterus. Quickly assess and transport the patient. There's nothing you can do. That is going to be, they're going to have to perform surgery. You can't, there's no other way to get in there to fix anything. And again, you have two patients with potentially life-threatening injuries. Support the airway, give oxygen. You can place some sanitary pads on the vagina, but nothing goes inside. And call for ALS backup. Remember to put your patient in the somewhat of a left-leaning position so that the weight of the child is not pressing down on their vena cava. Improper positioning of the seat belt can result in injury to a pregnant woman, as well as the fetus if they're involved in a motor vehicle crash. So carefully assess the pregnant woman's abdomen and chest for seatbelt marks, bruising, and obvious trauma. Remember, the bruising may not show up immediately. Um, a lot of you keep a high index of suspicion for this, even if your signs aren't quite there yet when you arrive, because they may start to show up later in the call. So whenever you're doing your secondary assessment, your ongoing assessment, keep looking and see if you start to see the development of a bruise that may not have been there when you first assessed. All right, if a pregnant trauma patient goes into cardiac arrest, your focus is the same as with any other patient. So remember that the only chance you have to save the fetus is to do all you can to save the mom. If the mom dies on you, the baby is, especially if you're not in the hospital, the only chance of survival for the baby is pretty much an immediate C-section, which we cannot do in the field. Thank God, I don't want anything to do with that. But if it looks like you're not going to save the mom, do CPR to the absolute best of your ability to keep blood flow going to the baby, and keep your fingers crossed, because a lot of times that doesn't really work very well, but we do the best we can. If a woman's in the last month or two of pregnancy, compressions may need to be applied a little bit higher. We teach that in CPR. We talk about it in choking. If they're too large or if they're pregnant, you can't really put your hands always right where you need to. So get a little bit higher up. Just understand that you're compressed. The higher up you are on the breastbone, the harder it will be to give an adequate compression. So you're going to have to press harder, and your hands may have to feel like they're going a little bit deeper into the chest to make sure that you give an adequate compression to the heart. If possible, one provider should be assigned to manually displace the uterus. So you can't really do CPR with a woman not being on her back. So if you have the help, have a second EMT or a first responder or anybody, because they're taught the same thing. Uterine displacement is where they just kind of straddle the patient, grab the baby, and lift up. They're only going to get a couple inches, but that's all you need. You just need to make sure that that weight is off the vena cava, so that when you're doing your compressions, you're getting good blood flow, because otherwise you're just pumping on an empty heart. You should notify the receiving facility personnel as soon as possible that you are en route with a pregnant trauma patient in cardiac arrest, because you shouldn't be the only one with a pucker factor that bad. Let them have some fun too. For your assessment and management, focus on the assessment and management of the woman. As long as you can keep her stable, usually the child will be stable as well. You should suspect shock based on the MOI. Even though they can lose more blood, they're more susceptible to it, especially when they're in a bad MOI. Be prepared for that vomiting and anticipate the need to control their airway. Attempt to determine the gestational age to assist you in determining the size of the fetus and the position of the uterus. As they get closer to going into labor, the baby's going to start to invert, and then unless something is wrong, because there are times where pregnancies don't work this way, but normally the child will invert head first and start to work its way toward the vaginal canal. So depending on how far they are in their pregnancy will determine the position of the child. If they're really, really late stage, the bottom of the belly is going to be pretty much the head of the child. So you can kind of get an idea of what that MOI might have done to the baby as well as the mom. All right. Follow these guidelines when treating a pregnant trauma patient. Maintain the airway just like normal. Just be aware that they're probably going to vomit, so you need to make sure you have your suction. Give high flow O2 at a high level. For pregnant patients, we don't worry with the titration because it's not just her, it's her and the baby. So just high flow O2, 100% non-rebreather mask, and go ahead and flood it out. That's perfect. It's okay for a pregnant patient. If they're just pregnant, then no, you can dial that back. But if they're third trimester, 15 liters non-rebreather, 100% oxygen. I wouldn't even worry about the O2 sat. Ensure adequate ventilation. Remember that moms may breathe on the higher end of your normal scale. They'll be closer to the 20 than they will be the 12. If the patient's ventilations are inadequate, you're going to have to bag them, even if they're awake. If you can't coach them to pick up their breathing, you're going to be like, look, ma'am, follow my advice or you're not going to like the outcome, but that is what it is. Assess their circulation. So control any external bleeding as best you can. Um, Maintain a high index of suspicion for internal bleeding and shock based on the MOI. Keep your patient warm. And when you're transporting, transport on the left side. It doesn't have to be completely on their side. If you can just kind of prop them up a little bit to where they're at a 45-degree angle, that's fine. Whatever's comfortable for the patient, just not straight up supine. That's not going to be good for them. If spinal injury is suspected, um, you can put them on a backboard, tilt the backboard 30 degrees to the left. The easiest way to do that, if you're transporting, the handrails for your stretcher, if you were to prop one side of the board up on one of those handrails and fasten it into place, that's about 30 degrees. It's an easy way to do it. In fact, a lot of them have the top of those handrails now on current stretchers that I'm seeing have a big rubber top to them that's kind of like an anti-skid, and it's for that reason. So that if you do have to hike the board up on one side, it's less likely to slide off so your patient doesn't get hit again. And then transport to your nearest trauma center. All right. It is 7 o'clock. Take a break, 10 minutes, and we'll pick up where we left off. All right, I'm gonna get back on it. Cultural value considerations. Um, so, obviously we live in a country where not everybody's the same, not everybody thinks the same, and that's a great thing. And it would be really boring if we did. But with that comes the fact that you may be walking into somebody's house with a very different cultural mindset than you. For example, Muslims, if you're a guy, they're not going to let you anywhere near the patient just because it's you can't do it. They won't allow it, and it's not they're not being mean. That's just their culture. Women of some cultures may have a value system that will affect the choice of how they care for themselves during a pregnancy. They may not want medications. They may not want to go to the hospital. Some just want to do it right there at the house, and that's within their capability and their choice. And they may call you out to help, but there's no transport option per se. It's just um, you help deliver, and then hopefully it should be like a certified midwife or something because there's training for that. But somebody in the house should be trained to help with the postpartum care and care for the child and everything that because they can't expect you to just stay there. That's not how it works. But um, sometimes you'll run into that. Some cultures may not allow you to help because you're a male. They prefer or rather, if you're a male, because some obviously a lot of y'all aren't. But if that's the case, especially if you can glean that information ahead of time, try to get a female to go either in your place or with you if you don't have one already on your truck. A lot of ambulance companies try their best to have one of each gender on a truck. That way that you can get around these, but there's no way to guarantee that because we can't guarantee 50-50 employment, right? I mean, we don't know if an ambulance company is going to have more guys, more girls, the same amount, that kind of thing. Regardless, you should respect the differences and honor the request from the patients. Your responsibility is to the patient and is limited to providing the care and transport. That's it. We don't fix things going wrong with pregnancies anyway, so don't try to force it. A competent, rational adult has the right to refuse all or any part of your assessment or care. That includes pregnant ladies. You can't force it. Sorry for not changing the slide, but this slide basically just says what I mentioned. Teenage pregnancy. We're number one. Congratulations. We are one of the highest teenage pregnancy rates in developed countries. That's not just first world countries. That's pretty much all of them. It is likely that during your career, you will respond to a pregnant teenager who may or may not be in labor. And again, they may not know they're pregnant. They may know they're pregnant. They don't want to admit it. It just, whatever, if they don't want to tell you, they're not going to tell you, even if you get them by themselves. So even if you put them in the back of the truck, they're by themselves, and you say, "Are you pregnant?" Or is there even a chance that you're pregnant? They could still be like, "Nah, not pregnant." So for your treatment, every girl that's able to be pregnant is pregnant until proven otherwise, which will happen at the hospital. As you begin to assess all female teenagers, remember that pregnancy is a possibility because another thing, like I said, a lot of times it may be that they thought birth control would help them and they didn't realize that things like antibiotics can screw that up. And that's not the only thing. There's other things out there, but they either weren't taught that, the doctor or the nurse may have forgot to mention it, or they were taught. And if you're anything like I was as a teenager, you forgot it before you left the room. So become familiar with the laws in your state so that you will know when pregnant teenagers can give or refuse consent for themselves. Remember back to when we were going over the laws and ethics chapter at the beginning? What's one of the things that could let a 16 or a 17-year-old make their own decisions? Yeah, you were quick for that one. Emancipated minors, right? If they already have a child, then they are seen as an adult in the eyes of the law. There may be places out there where that's an exception, but I don't know of any. So, um, did you have a child? I don't. What was that? If you want to even mention it, I don't know. What got you emancipated at 17? I know some people get it due to hardship of various types. It's called the military for y'all, for both of y'all. I wanted to move out of my house and couldn't unless I was 18. Well, I mean, hey, I didn't go the emancipation route, but moving out was my 18th birthday present to myself. So there you go. All right. Patient assessment. Childbirth is seldom an unexpected event. Sometimes it is. Well, the childbirth is seldom an unexpected event, but I mean, it still holds true. Sometimes it is. There have been people who did not know they were pregnant until the child came out. That's I haven't seen that in person, but there's enough of it out there that's made it into curriculum. Sometimes people just attribute it to bad food and weight gain, and they I guess they never noticed the kicks or I don't know. But dispatch protocols usually include the dispatcher asking simple questions to determine whether birth is imminent if they know that it's pregnancy. If nothing is said about pregnancy, they're not going to ask those questions because they just don't know. And yeah, no, it does happen. People will go their entire pregnancy and not know it. Premature contractions may be caused by trauma or medical conditions, and that's the thing too. Even when you get to that point, um, it may be that the patient starts trying to figure out if it's maybe their period's finally getting ready to start, or they think, well, I got hit or I ate some bad Mexican food and that's causing the stomach aches, or I mean, they don't always know. So for your size up, everything is the same. Take your standard precautions, BSI scene safety. Um, don't be lax in your safety observations and precautions. All right. Yeah, you're going into what looks to be, or what you would think at face value may be something that's completely safe. But like we talked about when we talked about addictions and stuff like that, or even cultural differences, sometimes you just walking in the room may be enough to seriously offend and upset somebody. If they're real quick to get angry, because lots of people have anger management issues and stuff like that. Um, you walk in the room ready to go see the patient, and suddenly you're at threat of being jumped on, that kind of thing. So don't get tunnel vision. Make sure you get a good view of the room. Um, if you're walking into a household that is a demographic that you know has a cultural difference, before you approach the patient, make sure it's okay. That kind of thing. Like, for example, like I said, if you walk into a Muslim household, if you see things that say Muslim, either in their decorations or like if you see a prayer blanket or something like that, stop and ask. Be like, all right, I understand, I'm a male. Um, are you okay if I give this patient care, or do you want to try to get a female on the scene, that kind of thing, so that you don't just walk in and ignore the family and get jumped from behind because they think you're about to defile the woman in the house. All right, for your mechanism of injury or your nature of illness, just know that not everybody that you go to that's pregnant is going to be in labor. They could be anywhere in that 9-month range. So don't get the tunnel vision there either. It's not, pregnancy alone is usually not the reason you were called to the scene. It could still be anything under the sun. Pregnancy is just thrown into it unless you were called because they're going into labor. So, the mechanism of injury could be the car wreck. You got to deal with all the damage to the mom. But if they're 6 months pregnant or 5 months pregnant, then that complicates things, at least a little bit. It doesn't really change your assessment, but you can expect vital signs to be different. You can expect more blood loss. You can expect blood loss to be more of a problem than normal, that kind of thing. And it also makes you want to think more about C-spine because they may have fell. Like I said, those joints loosen up. They're more likely to just, like, they'll be walking downstairs and their knee just give out because the joint's loose. So they suddenly can't support their weight. They come crashing down. Your primary assessment doesn't change Start with your general impression. Is your patient sick or not sick? Don't worry about your rapid exam in this sense of it. I just want you to look at them at like across the room and be like, okay, I see 2 arms, 2 legs, you know, all 10 fingers. The patient's awake, that kind of thing. But you're not poking and prodding and looking around and all that stuff. That stuff comes later. Um, Check your ABCs. There really shouldn't be any difference in this. If they're late stage pregnancy, just go ahead and give them high flow O2. Like I was saying, you're not so concerned about titrating to that 94, 99%. So just give it to them old school. Everybody gets a non-rebreather. The only real life-threatening condition in your A and B is if if your patient is having a altered level of consciousness, they're not going to be able to keep their airways clear. Then with that higher chance of vomiting, you really do run the risk of needing to suction more. So just equate pregnancy with bring the suction. That way you've got it if you need it. Remember that their diaphragm is not going to be able to contract downward as easily. So their breathing is going to be shallow and more rapid. And with that usually comes a lower CO2. And we've already talked about the sign or the things that that does. Um, it also means that they may struggle to keep their oxygen levels high. That's why I'm saying give them high flow O2. For your transport decision, if delivery is imminent, prepare to deliver at the scene. Deliveries, even in the back of a truck, don't happen while you're going down the road, and they don't happen with only one person. So a lot of times, if you're the one on the ambulance, you're going to want a rider. This is one of those calls where you start begging the fire department to let one of the guys ride with you. And then even then, if you think you're going to wind up delivering the baby, um, the paramedic may you're going to stop the vehicle regardless because you don't want to do this while you're going down the road. But the paramedic may have the driver get out and come back there and assist with it as well. I don't know, Wesley, if that's happened to you or anybody else that drives on the ambulance right now. You've had to assist in childbirths. Um, awesome when it happens well. Sucks when things go wrong. All right. If you're it, if the buck stops with you and you're the one that's getting the back of the ambulance set up, if you think that the baby's coming, go ahead and start prepping things, right? Turn the heat up. We already know that the big thing is we need to keep mom and baby warm. So heat goes on max. It's not your comfort. You may be sweating like a pig, like a stuck pig or a whore in church or whatever you want to, whatever saying you want to say, but it's about the patient. So make it hot in there and go ahead and get your OB kit out, which will show you at boot camp how those work, what all goes into those. Um, get everything set up. The less you have to do when you get ready to actually catch the baby, the better. You want to have everything on, um, everything out, ready to go within reach, because you're going to be trying to, like when you go to cut the cord, for example, um, your hand, you're gonna at that point you're going to be covered in slime basically. Um, it's really hard to do things when you have to reach way out of the way to grab something, or God forbid, you didn't open something and now you need to open it with slick fingers or only one hand if one hand is busy holding something else or whatever. So get as much of it set up as you can. Get your area set up in advance. If the delivery is not imminent, um, go ahead and try to close that gap between you and the hospital. Hopefully you get there. That's great. But just expect, if the mom is starting to crown or she's really dilating and everything, you're probably going to have to stop on the side of the road. Provide rapid transport for pregnant patients who have significant bleeding and pain, if they have high blood pressure, if they are already having a seizure, because again, that's the end stage of the pre-eclampsia, eclampsia stuff, and that's life-threatening to both the mom and the baby. And if they have an altered mental status, and be prepared too, if it's an altered mental status because of a drug or something, your baby is going to have the same problem most likely when they come out. Obtain a thorough obstetric history. So, depending on how far away they are from the due date, you may ask, when's the last time you had a period? Or it may be, when are you due? Um, If if it's early in the pregnancy or they may not know they're pregnant, you'll be asking more about their cycle. If you're a decent range into the pregnancy, it's more about how long have they been pregnant, what's their due date, that kind of thing. If they have any complications, if she has been receiving any prenatal care, and get a complete medical history, and also ask questions like, how many children do you currently have? Is this your first birth, second birth? Have you ever had a miscarriage before? I know that's a tough question, but you need to know that, because if they have, then they're at a high risk to have it again. Um, and not just miscarriages. If they've got 3 kids, ask them if all 3 were normal deliveries. They may have had one that was a breech, which we haven't talked about yet. That's going to come up in the next section of this chapter. But if they've had it before, they're susceptible to it. They probably will have it again, or at least they're at risk of it. So you want to be a little bit aware of that. Get your sample history. There's really not any difference to this. Just, signs and symptoms, allergies, pregnant medical history, medications, last oral intake, and then the events leading up to, which if they're pregnant, the events leading up to it. They're calling 911 because one or two things. Either A, it's a normal call and they just happen to be pregnant, or B, they're going into labor. So the events leading up to really pertains more to a traditional call that they just happen to be pregnant. If it's the events leading up to, well, 9 months ago, mom and dad did a thing and that led to this. So you don't really have to harp too much on that one. If the water is broken, ask whether the fluid was green. One of the issues that we may run into with childbirth is meconium staining, which is where the baby has had a bowel movement inside of the sac. It discolors the meconium, but the problem is that stuff is going to get inside the baby's airway if we're not careful. So um, they're at a high risk of infection, both the child and the mom. If their water broke and you don't see it, if let's say it broke at the house and then they drove to your station or something, ask this question. It's a good question to get in their sample history. For your physical exam, perform a complete assessment of every major body system that's needed, with emphasis on the patient's chief complaint. So if they tell you that they are having a hard time breathing, you're still going to assess everything, but you're going to focus more on the airway and also consider the position of the baby, because remember, that can affect how they breathe. It may be that or if they tell you they passed out, they may have passed out because they laid on their back and the baby put pressure on the vena cava and it caused a syncopal episode. These are things that pregnancy can cause these issues. So tailor your assessment to what they're complaining about, but don't rule things out. Don't be like, oh, you're complaining about lightheadedness and trouble breathing, so I'm not going to worry about trauma. Or, they may not tell you they blacked out because they may not know that they blacked out. A lot of times you don't realize it unless you're walking and you fall down or something like that. But if you're just sitting there watching TV, you may black out. And when you come to, you have no idea. You just, at most, you may think you zoned out for a minute, that kind of thing. But then you start to experience pain, or you have a seizure, call 911. And that whole syncopal episode thing, you don't even think to say it. So try to be thorough. Understand this is one of those call types where they'll tell you one thing and then tell the hospital something completely different. It's not necessarily that they're lying to you. It's that when you ask the question, they may not have remembered it, they may not have thought about it, but as they're stewing over things while you're on the way to the hospital, they're going to start to either remember things or they're going to start connecting dots. And then they're going to tell that new information to the hospital, and hopefully the hospital nurse doesn't just look at you like you're an idiot because you didn't put it in your report or treat it or whatever. And it's like, look, they never told me this. If I'd have known, they changed my tactics a little bit. Your vital signs, make sure you get everything. All right. Skin color, temperature, condition, blood pressure, pulse, respirations, pain scale if there's any pain. Make sure you get your neuros. Pay close attention to their vascular vital signs. So their pulse, their blood pressure, late stage, they should be a little high, but they shouldn't be way out of range. So, pulse 60 to 100. If they're rocking around 100, that's fine. You can expect that. That's all right. If they're sitting at 150, that's a problem. Same thing with their blood pressure. If their blood pressure is rocking 130, 140, that's a little high actually. But if it's way up there, like 160, 170, or even higher than that, then that's where your red flag needs to be put up. Um, Hypertension, even if it's mild, can indicate more serious problems. So that's why I'm saying, like, you should still be in a normal range. Um, and with hypertension, even though a little bit high may not be the problem, we don't know because they may have normally been hypotensive, and then that little bit of a high is actually a bigger jump than what they're used to. For your reassessment, every pregnant woman is an unstable patient, um, regardless. That's a big easy way to look at it. It doesn't matter how mundane the call winds up being. If it warrants an ambulance and they're pregnant, it's an unstable patient. Just every 5 minutes for your vitals, recheck your interventions. Hopefully, unless it's a trauma call or something of that sort, you're you don't really have to do too much in their primary assessment. But unfortunately, like I said, sometimes you do. Um, is vaginal bleeding slowing, or any of their, if they're losing blood, if their vital signs were out of whack, or is any of it getting better? Is it getting worse? Is it staying the same? That kind of thing. If delivery doesn't occur within 30 minutes, provide rapid transport. You really should be transporting anyway. Like I said, in my experience, in every paramedic I've ever worked with, as soon as they hear pregnancy, they throw the person in the truck and go, because with any luck, they can get to the hospital before it's too late. Nobody wants to deliver on the side of I-59, and it sucks when you have to do that. Make sure you document fully, communicate with the hospital. Um, yeah, no, I think a few of us have delivered on the side of 59. Let's see. When you communicate to the hospital, make sure they understand that you're dealing with a pregnant patient, even if it's not a pregnancy emergency, because depending on what the problem is, they may still need to get L&D involved. Let them know how far into the pregnancy your patient is, if they know what the due date is, depending, like I said, first half, second half of a pregnancy, you're going to be looking at this from different aspects. Is it, how long ago did they possibly get pregnant, as far as are they late, or if it's well into the pregnancy, then you're looking at how much time might be left. Any complications that you run into, um, how many kids have they had prior? There's a couple of terms that we'll go over as far as like prima gravida, that kind of thing. Is this the first child, second child, third child, whatever? If they've ever had any spontaneous abortions, any of that information, let them know, because the more knowledge they have, the more they're able to prepare when you get there. There's been times where we've delivered a child, or I'm sorry, we delivered a pregnant lady to the hospital, and almost half the L&D floor was down there in the ER waiting on us when we got there, and they didn't even stop. They just took her, said thanks, and ran off to L&D. Um, if we hadn't have told them everything, then we'd have been sitting in the ER with a twiddling our thumbs with a continuing emergency while L&D tried to react. Um, if delivery occurs in the field, you'll have two patients to take care of, and each one gets their own patient care report. So you're going to write two reports at that point. All right, for the stages of labor, you have three stages. You have the dilation of the cervix, delivery of the fetus, and then the delivery of the placenta afterward. First stage begins with the onset of contractions and ends with the cervix, is when the cervix is fully dilated. This is usually the longest, especially when you're dealing with first-time parents, or even second-time, third-time parents. So the more children somebody has, the faster this part goes. On average, you're looking at 16 hours for the first delivery. Um, some people have been known to go into contractions in this stage for up to 24 hours or more. If that's any of y'all, my hat's off to you. I would go insane. Um, the onset of labor starts with the contractions of the uterus. And when you're measuring contractions, it's from the beginning of one to the beginning of the next. It's not about how long one lasts, and it's not about how long they go between the contractions. It's what's the time gap between each one starting? That frequency will increase with time, and the uterine contractions become more regular and last about 30 to 60 seconds each. Labor is generally longer in prima gravida. Again, that's one of those terms I just mentioned, prima being prime. So the first, and then gravida is basically pregnancy. In a multigravida, which means just anything beyond the first child, the labor is shorter and it gets shorter and shorter. When they reach child 6, 7, 10, whatever, it may be water broke. Oh, there's a baby. So a woman may experience preterm or false labor. This is called Braxton Hicks. So they'll feel like they're going into labor. They'll have the pain, the contractions will be there. A lot of times though, with Braxton Hicks, you don't have that water break. So they'll just go into contractions, and you ask them, well, when did your water break, or did it? And they're like, I don't think it did. It's probably Braxton Hicks. But it could also be a couple other things that are emergencies. So if this is what you're dealing with, don't write it off. That's the big thing. Just because it may be false contractions or false labor doesn't mean that it's not something they need to go to the hospital for. So go ahead and take them and let L&D, or at least the ER, do a sonogram and some testing and stuff that we can't do in the field. And hopefully everything will be fine, and they'll either have the baby or they'll go home. Some women experience a premature rupture of the membranes in which the amniotic sac ruptures too early and the fetus is not developed or ready to be born. We had this whole conversation a little while ago about, what's the minimum age, or what's the minimum week for viability. Sometimes it unfortunately just happens too soon. These are spontaneous abortions, miscarriages. Your patient may or may not go into labor, depending on how far into the pregnancy they are. It may just pass, and they don't get that urge. The body doesn't get that urge to contract, so they won't have those pains. You will need to provide supportive care and transport to the hospital. Remember, this is devastating beyond any kind of word. There's nothing you can ever say to a patient to make them feel better. Just be there for them to try to cope with what's going on. Toward the end of the third trimester, the head of the fetus normally descends into the woman's pelvis, so the baby will be upside down. Normal delivery is head first. If you see anything other than the top of the head, that's a problem. All right, and we're going to get to that in a little bit, where there may be an arm or a leg or a part of the umbilical cord sticking out. Those are some definite oh shit moments that you hope you never see, but if you do, we'll teach you what to do for that. All right, the second stage, this begins when the fetus begins to encounter the birth canal, and ends with the delivery of the newborn. So once they start to crown, which is where the vaginal opening expands and you can start to see the baby's head, that's where the second stage starts, and it continues until the baby is out. During the stage, you'll have to make the decision about helping the woman to deliver at the scene or providing the transport to the hospital. At this point, it's make or break. And there's no way to tell you what the best answer is. Are you 5 minutes from a hospital, 30 minutes from a hospital? Like I said, things have gotten better. That Poplarville ER is a good spot to go. Not that long ago, that hospital didn't exist, so it really sucked when we had a patient show up and they were already crowning. Uterine contractions are usually closer together and last longer, and under no circumstances should you let the woman sit on the toilet. That sounds like it should be common sense, but you'd be surprised. The problem is that, especially for women that don't know they're pregnant, they're going to start to get that urge to push, and that's exactly what they're going to want to do, is go to the bathroom. So they're going to be like, I'll be back. I got to go use the bathroom. And if the bells are going off in your head for pregnancy, stop them. All right. And then, like I said, crowning, if you're not sure, crowning is where the head of the baby starts to show through the vaginal opening. And they'll measure that in the hospital, or you can do it yourself. They measure it in centimeters. So you can determine how much dilation the mother has got by how many centimeters is it from the left to the right side. And as the baby starts to push through more and more, obviously that length is going to grow. The third stage of labor begins with the birth of the newborn. So once the child is out, that's when the third stage begins, and it ends with the delivery of the placenta. So during the third stage is where You're warming the baby, you cut the cord, you hand the baby to the mom. Congratulations and cigars all around, and now you got to get rid of the placenta. It's basically a second birth or third birth if it's twins or whatever for the mom. The mom's got to pass that placental sac out as well. Um, this can take up to 30 minutes. So a lot of times you may be at the hospital. If you weren't at the hospital by the time the child came out, you're probably going to be at the hospital by the time the placenta comes. All right, consider delivery at the scene. If it looks like the child's going to come in the next couple of minutes, and again, remember that the more children they have had in the past, the less time you've got. So some questions you want to ask. How long have you been pregnant? When are you due? Is this your first pregnancy? Because if it is, then fantastic, you've got time. Great. Are you having contractions now? How far apart are they? And remember, it's the beginning of one to the beginning of the next. So, if she's got a 60-second contraction, a 30-second break, and then another 60-second contraction, it's 90 seconds, right? It's not that 30-second break. It's not the first contraction. It's the first contraction plus the break. When the second contraction starts, that is the time between contractions. How long do they last? Have you had any spotting or bleeding? That's a sign of trauma, either, especially like if it's early pregnancy, we're talking about ectopic pregnancy. If it's late, then we're talking more about abrupto placenta or placenta previa. And then that question should be followed up with, does it hurt? If it hurts, then it's the more serious of the two, because that means the uterine wall has been ruptured. If there's no real pain involved, then most likely what happened was it was placenta previa. The placenta attached over the cervical opening, and now that she's going into labor, that sac is in the way, and it probably ruptured as the baby started trying to press through. Has your water broken? Okay, yeah, right slide. Do you feel as though you need to have a bowel movement? And do you feel the need to push? Those are natural progressions of labor. The mom is going to start to feel that urge when it's time to start pushing the baby out. To help determine potential complications, you can ask these questions, some things to keep in mind. Have you ever had a C-section? The problem with C-sections, if you've had them before, is that your abdominal wall in that area and the cervix itself had to be cut open. That's what a C-section is. So those areas may be susceptible to, I'm not really gonna say damage, but they may not function exactly like they should because they've been cut open in the past. Now there's scar tissue there where the cut was is a scar that may not contract like it's supposed to, and that inability to contract properly, even if there's no emergency with it, it could affect the ability of the mom to have a vaginal birth later. So I know that when my children were born, we chose not to do the C-section because we didn't want to not be able to do. We didn't want to limit our options later. And of course, my wife didn't want the scar either. But were any of your previous deliveries by C-section? Have you had problems in this or any previous pregnancies? Do you use drugs, drink alcohol, or take any medications? Do you know if there is a chance you will have multiple deliveries? If a mom's going to have birth and she's had any kind of doctor's visits, she probably knows. And it'd be nice for you to know that so that you don't, catch one baby and then not be ready for the next one. Does your physician expect any complications? If the patient says that they're about to deliver, take them at their word. So, pull over if you're driving. If you're not already on the road, then don't bother. Get in the truck, but don't even, I wouldn't even put the driver in the seat. Just be like, all right, come on, we're going to deliver the baby and then we'll go. Don't touch the vaginal area until you've determined that delivery is imminent. And once labor has begun, you can't stop it. All right. You can't slow it down, none of that stuff. Never attempt to hold the patient's legs together. It doesn't work. Do not let her go to the bathroom. That's going to not end well. Instead, reassure her that the sensation of needing to move her bowels is normal and that it means she's about to deliver. So yes, I know it feels like you have to go number 2, but really more of a number one. Um, if your decision is to deliver at the scene, remember that you are only assisting the woman with the delivery. You're not a doctor. Your role when it really comes down to it is just to play catcher. Um, but there's a way to do it. And again, we're going to go through this at the boot camp so you guys get hands-on practice with the mannequins and everything. But you really are just an assistant. The mom is doing all the work, and it's got to. What's missing at a home delivery? Think about it. Well, the doctor, yeah, but I mean, you can call the doctor. An epidural. An epidural is missing in somebody's living room. Pain medicine and all that prep is not there. So, um, I've that's I was fortunate in that the times I've delivered a baby outside of the hospital, it was usually like child number 5 or 6. It was definitely not the mom's first rodeo, and they got easier and easier for her with each pregnancy. So it really wasn't that bad. If you, for some ungodly reason, have to deliver a woman's first child in the field, which makes no sense considering how long they stay in labor, um, God help the mom, because that's a whole new level of pain they haven't experienced before, and there's no pain med for that. So it's going to make your life very interesting. So stay calm, even though the mom is screaming bloody murder, and reassure her while protecting the woman's modesty. So, like I said, get her in the truck, put a sheet over her knees. That's okay. Just make sure that it doesn't block your ability to do your job. Recognize when a situation is beyond your level of training. A normal birth is not beyond your level of training as an EMT, even as an EMR. You guys went through this chapter. Um, if there's any doubt, contact med control for a decision to deliver on the scene or transport. Your emergency vehicle should always be equipped with an OB kit. We're going to skip this portion because we're going to go all through this when we get to boot camp. Same thing with the patient's position. Um, I'll just say that you're going to have your patient kind of sitting in a reclined position. No, well, don't close her legs. You want to tell them to resist the urge to push, but don't close her legs. And yeah, lots of diesel. Um, this stuff with the patient's delivery, we're going to skip until boot camp. Same thing with the delivery itself. So we'll actually cut down on some of our stuff for the night. Post delivery care, I'm going to talk about for a little bit. So when we get down into the third stage of delivery, if the mother is able and willing, hand the newborn to her, and she will definitely be willing. She just may not be able. Um, well, I'll take that back. I guess that's not always the case, but normally the mother will be willing. Hand the newborn to her, and or place the newborn on her abdomen so skin to skin contact can begin immediately. Um, that helps warm the baby. Um, and it also actually causes a hormonal change in the mom, which will help to make the rest of the delivery go like it should. Dry off the newborn, wrap him or her in a blanket or towel, and when we suction the face, we start with the mouth first, and then the nose. And the easiest way to remember that is M comes before N in the alphabet. So we have to get the mucus plugs out of the baby's face so that they can breathe, because you remember they spent 9 months in the liquid bubble. You don't want an open airway at that point because they're just going to breathe all that stuff into their lungs. So the unborn child has mucus plugs in their mouth and nose that stops all that amniotic fluid from getting into their airway. We use a bulb syringe because it's a small enough pressure that it doesn't. I mean, you really don't want to use a real suction on a baby. Um, you'll use the bulb syringe, squeeze it once, hold it, put it in their mouth, let go of the squeeze. It will suction out whatever's in the mouth, pull it out, expel it to the side. Um, when you expel it, just keep it squeezed again, and then repeat the process for both nostrils. And then when you wrap the newborn, swaddle it up completely because body heat, they need to be warm. Babies don't shiver. Babies, the way that they do their body heat, I call them heat factories. They just physiologically produce it. There's no mechanical warming. Like when we get cold, we start shivering. Babies don't do that. So wrap them up, let that blanket hold in as much heat as you can. Try to get it to where the back of their head is wrapped as well, but not their face. You don't want to do anything that would compromise their airway, and then hand baby to the mom. And again, we will go through more of this stuff when we get to the boot camp. We're going to actually remember your boot camp is not a big test. I know some of you guys have been worried about this. Um, the top needs to be covered as well, right? Yes, top of the head needs to be covered as well because that's a big point of heat loss. Remember, your boot camp's not a test. There will be some benchmarks that you have to hit, but the boot camp is still training. So the stuff that I'm skipping until boot camp is just because we're going to spend a lot of time on it when we get there because we're still teaching you. When it comes to the third part, the third stage, don't tug on the umbilical cord. Let the mom pass it on her own. We call it massaging the fundus. There's a maneuver that you'll do, and again, we'll show you at boot camp how to get the mom to pass that part out. And it doesn't involve tugging because if you pull on it and rip it, um, you're kind of screwed. You see, some bleeding, usually less than half a liter, occurs before the placenta. Good God, before the placenta delivers and is normal. If they're gushing, a full liter, liter and a half, that's a major problem. Um, they do have extra blood because they had the child, but there's still a finite amount, and that amount is bad regardless. All right. Take another 10-minute break. This is a good point to take that break. Be back 5 after, and we will work on finishing up the chapter for the night. All right, guys. It is, oh, it's right at it. Cool. All right. We have roughly, actually, let me see, because I'm curious myself. So 31. Okay, yes, we got about like 35 slides left. Um, from here on, we're dealing with the stuff that can go wrong. All right. Unfortunately, that's just how it goes. We're going to end on a great note. Save the worst for last. So neonatal assessment and resuscitation. Follow your standard precautions as always. Always put on gloves before handling a newborn, just as you would anybody else. The newborn will usually begin breathing spontaneously within 15 to 30 seconds after birth. So you've got a little bit of time to clear the airway, like I was saying, suction in the mouth and the nose. But again, you want to be prepared for that and be ready to do it immediately because 15 seconds will go fast. A infant's heart rate typically sits between 125 and 150. So heart rate will be at about 2 times a second or higher. If you don't observe these, gently tap or flick the soles of the feet or rub the back. We don't do the whole neck pinching and or shoulder pinching and sternum rubs on infants, right? That's not what we want to do. They have reflexes at the bottom of their feet, in the palm of their hands, any of those, and um, if there's any alertness to them at all, those reflexes at least will work. So, but we want to try to stimulate them a little bit if they're not already turning pink and got a good pulse, all that stuff. So gently tap or flick the soles of the feet, rub the back. Many newborns require some form of stimulation. It is normal. So if you do have to do that, don't freak. So as soon as you start to get a reaction, position their airway, dry them off, warm them up. Don't forget the suction. Your tactile stimulation is what we were just talking about. To maximize the effects, you can position the newborn on his or her back with the head down and the neck slightly extended. So you're going to kind of put them into a sniffing position, slightly upside down, but not really. Just the head's a little bit lower. If necessary, suction the mouth and then the nose. And in addition to drying the head, the back, and the body with dry towels, rub the back and flick or slap the soles of the feet. That helps to stimulate them. Think of it like if you ever heard about old doctors would take the baby and slap it on the butt, or if whatever, if you saw it in movies, it's kind of pretty much the same thing. If necessary, suction the mouth and then the nose, and usually that is necessary. A lot of times those mucus plugs aren't going to come out on their own. Um, so suction nose, start with the mouth, then the nose. If you need to give oxygen, we use what's called the blow-by method. That's where you're going to take a non-rebreather, and instead of just actually putting it on the baby's face, you're going to hold it kind of like up close to the nose, but off to the side, so that the air blows out across the baby's face. That way, they're breathing in, not really 100%, but it's still pretty close. All right. Additional resuscitation efforts. Observe the newborn for spontaneous respiration, skin color, and movement of the extremities. Evaluate the heart rate. Remember, unlike an adult, a heart rate for a child does not just need to be present, it needs to be at least 60 beats a minute. If you're not getting at least one a second, you're going to have to do compressions. Um, if you're 60 to, I think it's 60 to 80, and I'm going to double check that. I'm pretty sure it's in here. But if it's above 60, but not by much, um, you're not really going to have to do compressions. It's usually because their respiratory drive is depressed, and then you're going to have to do some kind of respiratory effort to get them back up from there. Give me just a second. All right. Let's see. Observe the newborn for spontaneous respirations, skin color, movement of the extremities, that kind of thing. Sometimes they're going to come out a little blue, especially right after birth. It's okay. You just don't want them to stay blue, especially in their fingers, their mouth area, that kind of thing. If they're blue in their trunk, that's a little bit more of a problem. Um, they should be starting to turn pink pretty quick, but their extremities may be blue for a little bit right after birth. Less than 60 is compressions. It's either 60 to 80 or 60 to 90 is going to be resuscitative, as in respiratory resuscitation efforts. If chest compressions are required, use the hand encircling technique. So that, if you remember from CPR, the two thumbs encircling hands, um, especially for two-person rescuer, because you're not going to go anywhere if you've got two rescuers. You can do that stuff on the scene. If you're by yourself and you need to move, then putting the child in your forearm and using the two fingers technique is something you can do. That way you can do compressions while you're going from one location to the next. Here we go. So yeah, 60 to 100. If it's less than 60, you're going to do basically compressions. You can see that on the far right in the third section. It says begin chest compressions. If there's 60 to 100, then you don't have to do the compressions, but you are still going to support their respiratory drive. So rescue breathing, you'll do that, reassess after 90 seconds and see if it's improved. Perform BVM ventilation during a pause after every third compression. So this is a two rescuer EMT maneuver that you're doing with a neonate, preferably in the back of the ambulance. You think about it, this is where you delivered the baby. This is not your typical CPR that we teach at the AHA. All right, so if you see this, question, even though it's about cardiac arrest, don't default to your CPR training. They don't account for this, because infant is starting at, what is it, 1 month to 1 year. So neonatal resuscitation is its own training, and don't get it confused with your CPR training. But perform BVM ventilation during a pause after every third compression. So you're doing a 3 to 1, beat, 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 breathe, beat, 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 breathe. And the main reason is because so much of their viability comes from their ability to breathe. In CPR, at best, they tell you to do 15 to 2, which is great for an established, 1 month or more, or a child or something like that. But for a neonate, 3 to 1 has been the best odds. But anyway, this will yield a total of 120 actions per minute, so 90 compressions and 30 ventilations if you're doing this at the right speed. Any newborn who requires more than routine resuscitation requires transport to a hospital with a level 3 neonatal intensive care unit, which means hospital doesn't count. I don't know if Picayune counts. I'm not going to say that they don't, but that's something for you guys that work in the Pearl River County area, South Mississippi. Look into it. For those of you in Louisiana, Ochsner is pretty much God's gift to the medical field in all of the state. They're just the big dogs down there. So if there's anything that's owned by Ochsner, it probably has it if it's a legitimate hospital. But again, depending on where you work and what's in your area, check on that. About 12 to 16% of deliveries are complicated by the presence of meconium. Remember what we talked about for that. If you see meconium in the amniotic fluid or meconium standing on the newborn itself, and they're not breathing adequately, consider quickly suctioning the newborn's mouth, then the nose after delivery before providing rescue ventilations. This is not to include the initial suction to clear the airway. You just don't want to risk. It's bad enough to get amniotic fluid inside of them, even more so. But if it's toxic with meconium staining, it's just that much worse, because then they're going to have to fight infections. And children under a couple of months, there's a lot of research out there that is pushing away from giving them antibiotics, if at all possible, because it really wreaks havoc on them. And there's the fear of autism from vaccines, but there's actual legitimate studies that are linking too early of antibiotics to actually being more of a cause for autism than vaccines ever were. the vaccine argument became political, and unfortunately, but there's a lot of valid research is saying, if you have to give broad spectrum antibiotics to a child under like a month and a half or whatever, it actually is tied to an increased risk of autism. They don't know if that's the direct cause, but they're seeing the trend is kind of there. Research is still outstanding on it. So depending on how that research goes, you may start to see that pop up in some of your refreshers down the road. Anyway, all right, so let's talk about the APGAR score. The APGAR score is a standard scoring system used to assess the status of a newborn. It assigns a number value of 0, 1, or 2 to 5 areas of activity. You don't have to memorize this for school. However, you're going to want to know this in general. And this is actually, there's a tool, I say it's a tool, it's just a piece of paper. It's called the Brazlow tape that most medical bags have. All the ambulances carry it. And it has a ton of information, not just for you, but for the paramedic. So if the paramedic's delivering a child at 2 o'clock in the morning and he's having trouble remembering his own name, let alone the dosages for the meds he's got to give, all that stuff is on this Brazlow tape. Also on the Brazlow tape is the APGAR score. So if you're doing that and you're just doing a regular BLS delivery, you can still grab that paper and get reference for things like this. But APGAR is appearance, pulse, grimace or irritability, activity or muscle tone, and respirations. All right, for appearance, you really want the skin to be pink if it's a light-skinned newborn. And if it's a dark-skinned newborn, you want their membranes to be pink, like the palms of their hands, their lips, that kind of thing. Blue skin all over or blue mucous membranes signal a central cyanosis, and they're going to get less of a score for that. It's really, really uncommon for babies to get a perfect APGAR score on the first attempt because of this part right here. Usually they are a little hypoxic when they come out. So if you're quick to do your APGAR score, you're probably going to wind up knocking them a point for their appearance. Their pulse, if you have a stethoscope, great. If not, you can measure the pulse using the brachial pulse, the same place you check it for CPR, which is on the inside of the upper arm. A newborn with no pulse or less than 60 requires immediate CPR. If they're 60 to 100, they need to get the respiratory side of CPR, which means you're just going to give them oxygen or possibly bag them to get them, get their respirations up. Anybody remember how fast an infant is supposed to breathe? What's the normal give or take range for them? Close. Well, good guess. Higher. So an infant is 20. The way that I've always done it, 12 to 20 we know is an adult. So with the exception of the adult, when I'm looking at kids' respiratory ranges, I equate it to the minimum number or the maximum number is twice what the minimum was. So a child would be 15 to 30. An infant 25 to 50. 40 to 60 is probably not is probably right depending on what book you're looking at. Um, that's a little bit harder for me to remember. I've always just I remembered 12, 15, 25. And then the 15 is the minimum, so I double it to get the maximum for a child. 25 is the minimum, I double it to get the maximum for an infant. It just worked for me. You guys can try to remember it however you want to or need to or whatever. And if you're off by a little bit, that's all right. But my point being is that if you have a child that's breathing 12 times a minute, they're nowhere near adequate breathing for their child for their size. And an infant needs to be I would say if they're breathing at 20 times a minute, that's low enough to warrant using a BVM. All right, grimace or irritability for the APGAR. Grimacing, crying, or withdrawing in response to stimulus is normal in an infant. So flicking the bottom of the foot, they should pull their foot away from you. You can do a couple of other things. You can put your finger in their palm. When you ever notice how a baby will grab your finger if you put your finger in the palm? Um, as sweet as that is, it's just a reflex. So if they're alert, um, they should do it. You can use your pen. You don't have to use a finger. You can use like the pen you're writing your report with. See if they grab it when you put it into their palm. If you brush their cheek, they'll turn their head toward it like they're getting food or they're expecting food. All of these are actual reflexes. They're not taught this stuff. This is things that they come out the gate knowing how to do or expecting. These are some of the things that you can check there. Activity or muscle tone. The degree of muscle tone indicates the oxygenation of the tissues. So normally, because they spent 9 months in this position, they're going to have their hips curled forward, their knees are flexed, legs bent, arms are bent, um, and they're going to resist straightening out. So what you do to test this part, you just grab them by the hands, pull their hands apart like you're stretching their arms out, and then let it go. And you should feel resistance when you do it, not to the point of breaking them, obviously, but they're going to resist that. So you're going to feel their muscles try not to let you straighten their arms out, and then when you let go, they'll snap back to their spot. A newborn should not be floppy or limp. If that's what you see, that's poor muscle tone. A lot of times that's a neurological deficit or a oxygenation deficit. And then for their respirations, again, normal is 25 to 50. So they should be regular and very fast by what we would consider a breathing rate. And they should be able to cry pretty easily. If they sound weak, if they look lethargic and like they're falling asleep on you despite your attempts to stimulate them, that's a problem. If the respirations are slow, shallow, labored, or if the cry is weak, the newborn may have respiratory insufficiency and need assisted ventilation. With that is going to come that low pulse. So again, if you check their pulse and their pulse is sitting in the 60 to 100 range, which is significantly low for an infant, if you fix their respirations, a lot of times their pulse will start to climb because what one system does, the other system will follow. A complete absence of respirations or crying is a very serious sign. I'm surprised that I even have to say that, but there it is. So yeah, if the patient is treated like a normal human, that's all they are. They're just tiny humans. If they're not breathing, you got to deliver it. If they have a pulse that's either not there or is less than 1 a second, they're getting compressions. That is CPR. All right, breech delivery. Let me get to the right spot. Here we go. The presentation in the position like what you see in this picture is going to lead to a breech delivery. Remember, normal babies want to go head first. If a baby is not, for whatever reason they didn't rotate, then when the mom starts to go into labor, you might see a foot, a hand, anything other than the head is considered a breech presentation. Sometimes it'll be the butt. They may start to deliver butt first. Breech deliveries usually take longer. So you will often have time to transport the pregnant woman to the hospital. That's one of the saving graces is a lot of times you really don't have to deal with this completely in the field because you're not actually going to be delivering the baby in this way, or at least we hope you won't. However, if unfortunately you show up late enough in the game where say like the butt's already through the vagina, then yeah, you got the short end of the stick on that call. Provide emergency care, call for a paramedic. You will definitely want that higher level of care there. If the woman doesn't deliver within 10 minutes, then go ahead and transport. Sometimes that's the case. A lot of times, usually the case on earlier, like smaller numbers of kids. Again, that first child, second child range. That's where you might run into that prolonged point. If it's child 4 and above, 5 and above, then if they already managed to get the butt out, the rest of the baby's coming pretty quick because it's already about that size. Consult medical control, get them on the phone, on speakerphone. And these are the times where you're probably the doc's not gonna hang up on you. A lot of times if you call with this is an oh shit moment where the med director is gonna probably stop what he's doing at the ER and help you all the way through as best you can. Because this is a life threat to both mom and baby. They're not going to dismiss you out of hand like they would if you were calling about nitros, because you know what you're doing with nitros. Preparing for a breech delivery is the same as for a normal birth. So position the pregnant woman, same position. open your kit, get ready, place yourself and your partner as you would for a normal delivery. You're going to allow the buttocks and legs to deliver spontaneously, so just let the mom continue to push, supporting them with your hand to prevent rapid expulsion. We're going to go over this in boot camp, but I just wanted to say this to you here so you can hear it. You're not going to pull on the body. You're not going to do any of that stuff. What's going to happen is you're going to kind of catch and reverse. So let the mom push the body out, push the baby's butt and lower body out on her own. Once that happens, the head is usually almost always face down and should be allowed to deliver spontaneously as well. You may have to make a V with your fingers and position them in the vagina to keep the wall of the vagina from compressing the fetus's airway. So, especially if the baby can't come out for a bit, you want to try to keep the pressure of the vagina from collapsing the child's airway, because once the baby comes out and gets exposed to oxygen, that's usually when they get the impulse to breathe. If they're not completely out of the body of the mom yet, that's going to be a problem. And we don't want them to suffocate. So unfortunately, this is one of those exceptions, the other night when I said never put anything in a woman's vagina. If it's either that or the baby suffocates, you talk about getting the short end of the stick again, you're going to be stuck in a compromising position basically while you get to the hospital, because you have to maintain a gap for the baby to be able to breathe. And once you get stuck in that position, you can't come out of it until a hospital staff takes over. But a lot of times what will happen is they'll be able to help you get the baby completely out, or you may still deliver the baby in the field. It may have just taken long enough that you had to do that, and then just the baby was able to finally be delivered the rest of the way. It just took a little bit longer. Again, we're talking about with those kind of problems, early like new moms. And all of this is what we were just talking about. All right. So these are your presentation complications. These are essentially going to be breech deliveries, but just different body parts sticking out. So on rare occasions, the presenting part of the fetus is neither the head nor the butt, but a single arm, leg, or foot. This is called limb presentation, and it is basically just whatever the limb is. An infant with a limb presentation cannot be successfully delivered in the field. This is not something you can do. There's going to wind up being a C-section. So as scary as this is, essentially it's a drive faster moment. Get the patient to the hospital immediately. Don't necessarily do anything to try to stop the mom from delivering. So again, don't close her legs. Don't try to push anything back in, that kind of thing. Don't pull on it. Don't push it back in. Place the patient on her back or on her, with a little bit of her side, so that she's not putting pressure on her vena cava. You can invert if your stretcher will allow it, or if you can put something underneath the foot if you have her on a board, that kind of thing, just to kind of help with positioning. Stick something underneath the foot portion of the board so that it elevates her and let gravity kind of work, but just don't force anything back in. Don't forget your high flow O2. So she's going to get it. And then, yeah, that's pretty much it. You can't force the pregnancy not to conclude, but you can do a couple of things to try to slow the natural progression of it down. Prolapse of the umbilical cord. This is where the cord itself starts to come out of the woman before the baby does. The only real concern about this is that the baby's head may pinch the cord off, and then now there's no more blood flow to the baby. So you're going to kind of treat this a little bit like you would if the baby's head was stuck in the birth canal and shutting off the airway. You want to make sure that the cord is not pinched, because, again, the lack of blood flow will lead to a very fast cardiac arrest for the child. The fetus's head will compress the cord during birth. It's bound to happen. Just like your limb presentations, don't try to push the cord back in. It really doesn't do anything. There's usually time to get the patient to the hospital, and your job is to keep the fetus's head from compressing the cord. So same thing. If it looks like the child's head is pressing it, use that finger V technique to get in there and try to lift the baby's head off the cord a little bit. But again, if that's what it takes, you are stuck there until you get to the ER. So hopefully that doesn't happen. You can also place the woman in the kneaded chest position where you just kind of lay her back, or I'm sorry, kneeling forward, face down. So it's kind of, I don't know how you would describe this position. On her knees, leaning forward, face down. Either of these will help take pressure off the cord. Usually the cord is posterior to the baby, kind of closer to the pubic bones. So if the woman is inverted, that means the weight of the baby is going to be pulling away from the cord. Wrap a sterile towel moistened with saline around the exposed cord. Treat it kind of like you would treat any kind of evisceration, because it's an internal organ basically that's been exposed to dry air. And then give your patient high flow O2 and transport rapidly. Spina bifida is something that I thankfully have not come across in childbirth. Spina bifida is a developmental defect in which a portion of the spinal cord or meninges may protrude outside of the vertebrae and even possibly outside of the body. It's interesting because your cord doesn't actually go all the way to the end of your spine. It stops toward the top of your upper lumbar region. And then past that, you have all the nerves that are eventually going to run down your legs. They just kind of splay out like a horse's tail from there to the end of your spine. But sometimes the cord may extend beyond the spinal column and stick out. Cover the open area of the spinal cord with a sterile, moist dressing immediately after birth to help prevent a potentially fatal infection. That is going to be one of your biggest concerns. And then, of course, don't press on it. Don't pinch it. Don't do any of that kind of stuff. Maintenance of the newborn's body temperature is important when applying moist dressings. So if you have to do this, try to make it warm if you can. Make sure you cover the baby and don't let them get too cold, because hypothermia is really easy in an infant, like we were talking about. And I don't want you guys to have a child that you're so busy trying to work on something that you forget you have to keep the child warm, and then you run into that hypothermia issue before you get to the hospital. Multiple gestations. Twins occur about once in every 30 births. That's really common. Usually multiple fetuses are diagnosed early in pregnancy, so that's not going to be a surprise unless you have that call where the woman didn't know she was pregnant. But if you're pregnant with twins, surely you know you're pregnant. With multiple fetuses, always be prepared for more than one resuscitation, because it could always come out that both kids need it. And that can actually be pretty common too, because they're fighting for blood supply. You've got sibling rivalry going before they're even born. And then you also have to factor in, especially those cases where like the mom may be on some kind of medication or recreational drug that's going to complicate things even further. Consider the possibility of twins anytime the first newborn is small or the woman's abdomen remains fairly large after the first birth. Usually that just tells you there's something else there and it's going to be coming soon. If twins are present, the second one will usually be born within 45 minutes of the first. So that being said, a lot of times you may be the one that delivers the first one, but they'll probably be at the hospital by the time the second one. About 10 minutes after the first birth, they're going to start contractions again, and it's basically just the whole process over. The procedure for delivering twins is the same. You just have more than one baby, which means you're going to probably need more than one OB kit, and that's an issue because I know that when I left AAA, I don't know about now, Wesley, you can correct me if I'm wrong, and this was the same for Acadian when I worked for them, as well as pretty much everyone. We only carried one OB kit on the truck. They might have another one now, but it was a space issue because those OB kits are very big, and a lot of the cabinetry of an ambulance is small, depending on the ambulance that you get. But clamp and cut the cord for the first newborn as soon as it's been born and before the second newborn is delivered. So you're going to go through all of your steps with the first child before the second one. Don't sit there and let the first child freeze to death and not get disconnected and everything while you're waiting on the second child. Record the time of birth for each twin separately, and twins may be so small that they look premature. Handle them carefully and keep them both warm. Premature birth, this isn't always an issue, but it's still a abnormal birth. Doesn't necessarily mean that it's an emergency. There's preemies born all the time. A normal full-term single newborn will weigh about 7 pounds. I remember my daughter was 6 pounds 7 ounces, and my son was just a little bit over 7. Any newborn who delivers before 8 months or 36 weeks or weighs less than 5 pounds is considered to be premature. So again, but if they're riding that line, it's not necessarily going to be that there's a problem per se. Premature newborn is smaller and thinner than a full-term newborn, and the head is proportionally larger in comparison with the rest of the body. The skull typically forms pretty fast. The body catches up, and it's like that not just at infancy. It's like that all through childhood, which we'll talk more about that when we do peds, which will be the next class. So the vernix caseosa will be absent or minimal on the premature newborn, and there will also be a lot less body hair. They just haven't had time to form that yet. Premature newborns require special care to survive. So these babies, when you call ahead to the hospital, let them know that it's a premature birth, and you probably are going to wind up needing the NICU to come down as well. They often require resuscitative efforts, especially if they're really, really premature. And it should be performed unless it's physically impossible. And so that's the thing. All right, we're talking about whether or not a child is viable. The 26-week, 24-week, 28-week, whatever, if they are physically formed enough for you to be able to do compressions on, why not? All right, if it's 24 weeks, why not? If it's physically impossible, in other words, it comes out and they're just not, they're not there yet, right? You really don't have the anatomy to do the compressions, then you can't do it. Because even if you were to try to keep it going, that's an unviable birth. But I don't want you to be like, well, it's been 23 weeks and 6 days. Can't do it. It doesn't, no, I don't want you guys to get that mindset. So if a child comes out premature, just look at the child and are you developed enough to receive chest compressions? And if so, then yeah, go ahead and work it. We already said all this stuff. I got ahead of myself on the slides. Sorry. All right, post-term pregnancy. This refers to pregnancies lasting longer than 42 weeks. This is where the baby just didn't get the memo that it was time to vacate the premises. Post-term fetuses can be larger than a typical 40-week fetus, sometimes weighing 10 pounds or more. This condition can lead to problems with the woman and the fetus, a more difficult labor and delivery, to say the least. And a lot of times, really and truly, this is going to wind up being a C-section, just because it's going to get to a point where they can't reasonably expect a vaginal birth because the child's just too large. If it's attempted, it increases the risk of injury. Also, the fact that the child is just bigger in general increases risk of injury. So more likely that they're going to have to do a C-section. And the woman is at risk of perineal tears, however you want to say it, and infection. Post-term newborns have increased risk of meconium staining, infection, and being stillborn, because if they miss the boat, remember, some body processes may go ahead and start even though the child hasn't been physically birthed yet. That includes bowel movements. So you're much more likely to see that. Newborns may not have been able to develop normally because of the restricted size of the uterus. That's going to start putting pressure on their skull that's not normally there, the fontanelles, which is there to allow their head to compress a little bit laterally so that they can pass through the birth canal. If they get too cramped up in there, the size of the uterus plus the fact that the skull is pliable can start to cause some major problems. So you should prepare to resuscitate the newborn if you're the one that somehow manages to deliver this baby out of the hospital. Respiratory and neurologic functions may have been affected. fetal demise. I've not heard it called this before. Um, they probably changed the term for the new curriculums. You may find yourself delivering a fetus who died in the woman's uterus before labor. The onset of labor may be premature, but the labor will otherwise progress normally in most cases. So, like I said, the whole labor thing is actually the mom's body's attempt to get rid of the baby, to deliver the baby when it's time. It's not the baby that decides that. The onset of labor may be premature. I already said that. If the intrauterine infection has caused the demise, you may note an extremely foul odor. Um, if some kind of bacteria got inside the amniotic fluid or something and it wound up killing the infant, or I'm sorry, killing the fetus, um, it's gonna stink real bad. The delivered fetus may have skin blisters, skin sloughing if it's been a while, and a dark discoloration. The thing about it is, remember they're in a wet sac, so when um, when the body dies, fluid shifts will happen, and the skin will actually start to slough off. The top layer will start to slough off, and that happens at any age. So try, I don't want you to have nightmares tonight thinking about this with babies, but that's just something that happens. Like if a person dies in a bathtub, um, getting them out can be a little difficult because when you grab them, you're just going to slide and skin's going to come with you. The head will be soft and perhaps grossly deformed. If this is what you're dealing with, if they're obviously dead when they're born, don't try to resuscitate them. This is one of those times where it's just not worth it. There's absolutely no reason. You can't do anything with the obviously dead. All right, delivery without sterile supplies. So if you're, um, let's say you get on a truck, you haven't had time to check out the truck yet. The previous shift didn't give you an OB kit, and before you had an opportunity to replace or to put one on there, somebody rushes up to you and says, "My wife's having a baby," and she's in the truck or she's in the car or whatever. Um, or God forbid you're the one that forgot to put an OB kit on the truck, whatever. If you don't have it though, you may have to deliver the baby. You can't just not deliver just because you don't have your OB kit. But even without an OB kit, you should always have your eye protection, gloves, and a protective mask with you. Carry it. You're going to basically do it as if you had the sterile supplies. It's just going to be a much messier thing, and you're going to run the risk of infection for the child and the mom. So try your best not to do anything internal if you can help it with normal gloves. All right. Remember, childbirth is a sterile procedure in an unsterile environment. We do the best we can, but it is what it is. As soon as the newborn is delivered, wipe the inside of the mouth with your finger to clean away blood or mucus because you don't have the bulb suction. So all you can do is just take your finger and swipe. You should not cut or clamp the umbilical cord. And instead, as soon as the placenta delivers, wrap it in a clean towel or put it in a plastic bag and transport it to the hospital. So you're going to keep the baby connected to it. Always keep the placenta and the newborn at the same level. So if you're having to carry it this way, um, put them side by side on the litter if you can. Have the mom try to hold the baby as best she can, but if she's going to hold the baby up to her chest, she's going to have to hold the placenta with the child at the same level. The main reason being is because the heart is not strong enough to build a blood pressure that is going to cause the blood that's going into the placenta to climb uphill to the baby. And then vice versa, if you held the placenta up, that's going to cause so much pressure within the baby that you run into even more problems with that. So keep them at the same level. Let the heart move blood laterally rather than either up or down. And then, of course, keep the baby warm. All right, postpartum complications. So remember we talked about bleeding. Sometimes it is common that they're going to bleed during the pregnancy. Usually about half of a liter, 500 milliliters is considered the upper end. Anything from that part up is excessive. If bleeding continues after delivery of the placenta, you should continue to massage the uterus. So we always called it massage the fundus. There's an area of the woman about an inch or so above the vagina, It's pretty much just like the top of the pubic mound. You're going to press in and massage there, and what that's doing is it's causing the um, the vessels that are right there to start to seal off and not bleed. It also causes a hormonal shift that tells the body, hey, childbirth is done. Let's stop the bleed and start to push the placenta out. Because remember, you don't pull it out yourself. The body's got to deliver it. So that massage will actually cause a hormonal shift right there on the spot that will start to help you with your bleeding. But check your technique and hand placement. If the bleeding continues, make sure you're massaging the right spot. You shouldn't be pressing on the bone. All right. You should be up above it a little bit, but not far. Treat the woman if she appears to be in shock, and you're going to treat for shock. Excessive bleeding after birth is usually caused by the muscles of the uterus not fully contracting due to delivery of more than one infant. A long labor process that causes the uterus to be too tired, like this just wore out. Um, and then parts of the placenta still being inside the uterus. So if the placenta broke apart, it could cause the bleeding to continue. If you can't stop it, treat it like when we talked about trauma to this area. Cover the vagina with a sterile pad. Don't put anything in it. Um, just place the pad there, let it soak up blood, swap it out because you're not sealing this down. You're just catching the blood. Don't discard them. Take them to the hospital with you because it tells the hospital how many pads or how much blood she might have lost. Administer oxygen. Monitor the vital signs frequently. This is a highly unstable patient. If there's continuing to bleed, it's a hemorrhage. And transport the patient immediately to the hospital. Never hold the woman's legs together or pack the vagina with gauze. It just doesn't work and actually winds up causing more problems. If the blood starts to coagulate inside the vagina, it can turn necrotic, and now they're going to have much bigger issues than just the bleed. Postpartum patients are also at an increased risk of an embolism, um, and this is most commonly a pulmonary embolism because it's going to follow the veins. Pulmonary embolism results from a clot that traveled through the bloodstream and became lodged in the pulmonary circulation, blocking blood flow to the lungs, and is potentially life-threatening. This is something that you won't see often, but this is also something that can turn a person south real quick, so be aware of it. If you deliver a newborn in the field and the woman begins to report sudden difficulty breathing or shortness of breath, this is most likely what you have. Also, suspect a pulmonary embolism in patients of childbearing age with respiratory complaints who have either recently delivered, especially with a sudden onset of difficulty breathing or an altered mental status. Just support your ABCs as best you can. Give them as much oxygen as you can, because if it's just one lung that can't operate, they still can get air from the other lung. But they need to get to the hospital as quick as they can so that they can get a surgery and take care of that clot. Any questions on tonight's lecture? I know there's a lot to it. And as far as the steps to delivering a child, we're going to deal with that at the boot camp. But from the lecture, I just want you guys to know basically like what's normal, what's not normal, and the specific things like abruptio placenta, placenta previa. Know the differences between those. So if there's any questions, if you need any kind of clarification on this, let me know. Like I said, this is a tough chapter. This is the one that most people fail on the registry. This is the one that most people just forget about it afterward too, because you may go 10 years before you ever need this information. Nothing. All right. Your pin for the night is going to be BC, so Bravo Charlie, 32. C is in Charlie. BC 32C. All right, guys. Happy Thursday. Happy weekend. Yeah, well, the good thing is this is probably the worst. This is one of those hard chapters to deal with. This is the last one of those. So we have two chapters left. We have pediatrics and geriatrics. That's going to be your young, obviously young and old people. Um, Pediatrics is a beast of a chapter. It's going to be even longer than this one. And we're going to do that on Tuesday. You'll have Thursday off because it's Christmas Eve. We'll hit geriatrics on the following Tuesday, and that will conclude your lectures. After that, it's just the boot camps. So we're on the last lap, guys. I appreciate y'all sticking with me for these few months, listening to me drone on for hours at a time. And now we're about to start the fun stuff because you're going to get to do all the hands-on. And again, don't be afraid of the boot camp. It's not a test. There are benchmarks you have to hit, but it's not going to be anything major. It's still a learning environment. But other than that, y'all have a great weekend, and I'll see you on Tuesday.